Today we have Dr. Ralph Clayman, extraordinaire again, pioneer of minimally invasive surgery. Basically, all we do nowadays, each and every surgery that requires urological minimally invasive technology and technique is due to Dr. Ralph Clayman, and he's been president of all societies that you can imagine. He developed technologies, has patents, has been a dean of medical school, professor and chairman of departments, and now he's here back in Jackson Hole, and during our Jackson Hole seminars, continue the legacy of Ralph Hopkins. Thank you very much, Dr. Clayman.
Thanks, Fernando.
I think the new generation of urologists and people in any other surgical fields, will ask in their minds, how did you come up in 1990, or even prior to that? How did you develop? What was the idea? Were you taking a shower and said, I'm going to do this, the first laparoscopic nephrectomy?
Yeah, it's a combination of basic background and opportunity, like everything else. So I got interested in minimally invasive surgery slowly in Minnesota because Art Smith came to Minnesota when he first came to the United States, and I was a chief resident. And so the endourology, he was developing all the endourology at that time. And then when he went to Long Island Jewish Hospital, I was just finishing my chief residency, and in essence, Paul Lang was the one who basically, quote unquote, convinced me that I needed to be doing endourology and perc stone removal and things like that. And because of that, I got into the concept of minimally invasive surgery. How can we do surgery and provide equal outcomes with less harm? That's the whole modus operandi of endourology. When I got to Wash U, eventually I got interested a bit in laparoscopy and had the ability to watch Ernst Friedrich, who was OBGYN, do laparoscopic procedures actually in his office. And through Ernst, who was very kind with his time, I got to meet Kurt Sem when he came out to Wash U. And so it was something that I kept on thinking about over the years, but in urology at that time, the only purpose for laparoscopy was looking for the cryptorchid testicle. Then all of a sudden, the gallbladder thing hit, and everybody in general surgery was thinking about doing laparoscopy. I was gifted a full array of laparoscopic equipment from Karl Storz by one of their representatives. I think it was Cynthia Drake. I had no idea what to do with it. And so I was there at Washington University. I had the equipment, which was getting very hard to come by because they couldn't keep up with the production because there was such a demand. And it was Sam Wells, who then basically was head of surgery, had me meet with Nat Soper, and they wanted to get into laparoscopic cholecystectomy. Sam knew I had the equipment. I also had a laboratory. We were doing all sorts of pig studies and everything else. And so he said to Nat, he said, you should work with Ralph, and Ralph will work with you and start doing choles. Nat had the idea that you could do the lap chole with electrocautery. Most people were using laser because they're afraid that the electrocautery would cause an explosion in the abdomen. So Nat actually, we started doing pigs with Nat. Lou Cavusi came in and worked with me at that time. And while we were working with Nat, we could see the pig kidney. While he was taking out the gallbladder, we're looking at the kidney, going, wow, the kidney's just sitting there. And so we had the idea, well, maybe we could take a pig kidney out laparoscopically. And so that's how that all began in the laboratory. So we began to work that technique out, if you will. And at the AUA, I was talking to Fred Romer. This is probably about 1989 or so. And I spoke to Fred. I said, we've got this thing in the pig, and we're doing this laparoscopically, but at the end of each procedure, we would make an incision to take the kidney out. And I said to Lou, this is really stupid. We're doing all this work, and at the end, we make the incision at the end of the case instead of at the beginning, but the end result is the same. It's an incision. And then we started using different things to sack the kidney, freezer bags and things like that. Then we said, well, maybe we should be able to break it up. And so we started looking at orthopedic shavers and other things to see if we could disintegrate the kidney, so we'd pull the whole thing out through a hole no bigger than the tip of your finger. Well, at the AUA, I spoke with Fred Romer, may he rest in peace, and Fred said, well, they have a morcellator for OBGYN. It works great. The problem is it also works on suction, so as soon as you put it in the abdomen, you suck all the CO2 out, you can't see anything. So as luck would have it, we started talking about it more. I said, well, we're sacking the kidney, so if you can make an impermeable sac, then potentially we could do this. And we then, from the laboratory work, we actually literally, it was a Patagonia sac that we started using because it was just the right size. And we found out we could sac the kidney in that, close the neck of the sac, pull it up into the 11 millimeter port, and then we could open the incision smaller and pull it out in the sac. Fred resourced the material that the Patagonia sac was made out of, and eventually came to us with a sac that was impermeable, that was modeled on that sac. And so we did some laboratory work, that seemed to go well, and then we said, okay, let's do it clinically. It's interesting because in those days, things could move very quickly. And I have to admit that I said, well, laparoscopy's been around since the early 1900s, and nephrectomy's been around forever. So laparoscopic nephrectomy, fine. And so about the night before, or 2 days before we were going to do the procedure, there was just something in the back of my head going, well, maybe you should speak to Dr. Catalona. And I vividly remember sitting on the floor of my, we had our bedroom on the 3rd floor, sitting on the floor up there and calling Bill and saying, Bill, we're thinking of doing this laparoscopic nephrectomy. A patient was sent to me by Bill Campbell. Yeah, she's very elderly. She's got a 3-centimeter renal mass. They think it's a tumor. Nobody wants to operate on her, but she's otherwise healthy. And we're thinking of go ahead and doing this on such and such a date. And there's this pause on the end of the line, and Bill goes, says, well, you should get IRB approval. And I went, oh, come on, IRB approval, it's going to take 6 months. And I gave all the excuses why you didn't need IRB approval, at the end of which Bill said, get IRB approval. If you don't, and it works, you'll be fine. But if you don't, and it doesn't work, they'll kill you. So I called and spoke with Phil Ludbrook, who was head of the IRB then at Washington University. I said, Phil, here's the situation, here's what we'd like to do. And so Phil, God love him, went ahead and said, okay, presented it almost immediately, fast-tracked it to the IRB board, and I got approval from the IRB to do 2.
Wow.
And so on June 25th, 1990, we went ahead and did this. Everything.
My birthday.
Oh, really? Your birthday? The only thing that went according to plan was sacking the kidney and morcellating it. That took exactly the same amount of time that it took in the lab, which was only 15 minutes. The other 6.5 hours was spent in dissecting out the kidney. And what we had come to realize, and we should have realized earlier, we were naive as could be, was that the pig kidney was totally different than the human kidney from the standpoint that the line of Tolt in the pig is medial to the kidney, as is the colon, therefore. And it just, and you go, how stupid. But so you're in there and you realize the colon's covering the entire kidney, and we embolized the kidney the morning of. We put up a ureteral stent, and you look inside, and the only thing you could see was the liver and then bowel. And we went, wow, this is foreign territory. And Nat Soper was there working with us, and we slowly began to go up along the line of Tolt. But for us, what was essential was finding the ureter, and we traced the ureter up, and in essence, dissected the kidney from underneath the colon. We never mobilized the full line of Tolt, never mobilized the liver. Wow. And so we're coming up on the vessels all from below, and nervous as can be because, you know, we're afraid of injuring the colon, continually pulling the kidney down with the stent up. And we erred, if you will, on the side of getting really close to the kidney. And so we wound up dissecting out 5 pairs of arteries and veins to the kidney, rather than taking the main renal artery and main renal vein.
I see. Yeah.
And we clipped them up, and then eventually the kidney took the kidney out.
And then you use what? The titanium clips?
Titanium clips. That's all we had were the 9mm clips. Yeah. So you couldn't do any vessel bigger than 9mm. We used a hook electrode to do the entire dissection. Fred Romer filmed. I have the original procedure on videotape because he filmed it that day.
Wow.
Yeah, so I have, and you can see what we were seeing on the monitor, and you look at that compared to what you see today, and you go, this is the difference between driving on the road in a spring day with the sun out versus you're driving in San Diego and there's fog on the road and you basically have your tires on the white line, you know. So we were very fortunate. Yeah. The good Lord absolutely smiled on us that day. God bless our patient, she did well. Required only 2 milligrams of morphine sulfate, went home on post-op day 5, but she went into congestive failure because they gave her too much, not too much, nobody knew what to do. And nobody had ever done any laparoscopic procedures longer than a couple of hours, and here we're at 6 hours and 45 minutes, and she became markedly oliguric, and then slowly the kidney function came back. But we were in totally uncharted territory at that time, but we were just very fortunate.
Wow, and you created a new generation of surgeons. Dr. Kubus is my mentor, and I've been so thankful to God for, you know, being part of that path. And not only that, you created an army of international surgeons, and that can help even exponentially other patients. I mean, this is amazing. Well, first of all,
you know, I mean, the Endourology Society, as Art Smith conceived it, and as it's gone forward, has been a society where everybody's welcome. Everybody's welcome to come into the tent, if you will. It's a tremendously collaborative group of individuals. Nobody's there standing on a podium beating their chest. Everybody is interested in everybody else's ideas. Yeah. And everybody, I think, brings to the table a significant amount of humility, which then opens them up to more discovery. In the absence of humility, you have no creativity.
And you have an annual meeting, and then you also meet during the AUA.
Correct.
And any other meetings that are, of course, there are some.
Yeah, no, it's the major meeting each year is the World Congress of Endourology, and that's been all over the world.
Right.
I mean, all over the world. And now that the attendance of that is upwards of about 1,500 to almost 2,000 people per convention, but we've been everywhere. We've been to Egypt, we've been to Israel, we're going to Abu Dhabi, we're going to St. Petersburg. And again, the opportunity to interact with urologists from all over the world has been a wonderful experience.
And each one bringing their adaptations for whatever socioeconomic reasons, not able to buy technology, and they adapt, and we learn that. I think it's just amazing. And then there's a video. And then
there's a video urology each year that are also established, and that's an international meeting.
And that's also part of the
Endourology Society, right?
And during the AUA, there's a society.
There's a society meeting, right?
So Engineering
and Urology
those are the
Society
three
meeting.
Important things.
Yes.
Right? So you've been pioneer, professor, inventor, family man, all that. But also, you've been a dean of the medical school.
Yeah.
Very active one. And there are a lot of stories about how great you were for this, to the students, to the residents, you know, bringing technology. But there's also this book. That, the complete dean. You know, first of all, I'm honored to receive this, but what really triggered you to write about this? And we talk also in this meeting about time management, burnout, and all those things.
Well, I mean, you know, what prompted me to write that is that I, like a lot of other deans throughout the country, you become a dean not based on the fact that you've gone to dean's school and you've graduated with honors and you're plucked out of, if you will, the academic milieu, and somebody goes, well, I think this person would be a good dean because they ran a good department of urology, or because they are incredibly world-renowned because of their research or whatever. And all of a sudden, the next thing you know, you go from a situation in which you're responsible, let's say as a chair, for maybe 10 to 20 people, or maybe even 100 people if you include administration, but all those people you know. The department's small enough that you know everybody in that department by first name, to a situation where now there are 3,000 people, you know, 2,900 of whom most of whom you don't know, and none of whom you've hired, but all of a sudden you're responsible for their actions. And now you're responsible for a budget that is literally 100-fold more than what you managed as a chair. And so you're ill-equipped to do this. Now, if you've had an MBA, probably or possibly, you're going to be better equipped. But most of the deans do not have an MBA, which is interesting, even in this day and age, when a lot more physicians are getting MBAs. So most of the deans don't have that experience, don't have that knowledge. And so the question arose, well, what can you read to help you get into this? And so I got every book I could that had ever been written sort of about being a dean, but it wasn't really a guide. It didn't provide me with, listen, in the first 3 months of being a dean, these are the things you ought to do if you're going to be successful. So I created a series of about 100 and some odd questions on being a dean and what it would take to be successful. I had it vetted by my entire team, my associate dean for academics, my associate dean for research, the associate dean for education, my right arm, my head administrator when I was dean, Rebecca Brusuelas, and they critiqued it. Also Tom Cesario, who was dean at our place for 12 years. And so I had all those people sort of critique the questions and then sent it out to all the deans in the United States who were presently active and had been in the saddle for at least 5 years or more, which is only 1/3 of the deans. So the average lifespan of a dean of a medical school in the US today is roughly 3 years. But I wanted to get input from people who had been successful in staying in the saddle. And so they were very kind. Out of those 60 some odd deans, 37 filled out the questionnaire, sent it back to me, and then my only job was to take 37 answers to question 1 and write it up, 37 answers to question 2 and write it up. So you could write it, here's a consensus, but here are some other interesting ideas. And that's how this book came about.
Yeah, that's a lot of work.
Yeah, but in all fairness, I was given, which is one of the suggestions there, is which I got from actually my former dean at the University of California, San Diego, Hal Simon, who, when I spoke to him about becoming a dean, very wisely said, whatever you do, just make sure that it's part of your contract that when you step down, you are going to get a sabbatical, that it's guaranteed. So unfortunately, I didn't get that in writing. It was just a verbal agreement. And by the time I was ready to step down after serving a 5-year term, the people who had made that agreement were no longer there. But kindly, Chancellor Gilman said, fine, I'll honor that. And I had a 6-month sabbatical, and that's when I was able to finish the book.
This is great. What type of, not advice or a good word that you give to the new generation of urologists who are preparing to the world?
You know, first and foremost, my feeling is that that being a physician is an incredible privilege. Mm-hmm. That regardless of how times change, regardless of how the paperwork changes and the electronic medical record and the reimbursement changes and the healthcare plan changes, what will never change is the relationship between a physician and the person who's coming to that individual because they're hurting and they're seeking their knowledge to relieve that pain and suffering. I really don't even like the word patient. I talk about people who have an illness that from which they would like relief. That will never change, and that is an incredible privilege. And in my biased view of the world, there is no other profession that provides you with that sense of worth, of having somebody stare you in the eyes and say, doctor, you've given me back my life. No amount of money will ever do that. Don't care what you do in this world, don't care how many millions or billions of dollars you accumulate. You will never experience that kind of sense of satisfaction that right there and then justifies your life. So, yeah, as far as the other advice goes, you got to know who you are. Yeah. First and foremost, sit down and figure out who you are. What do you like and what do you not like? If you just love taking care of people, and if you just love operating, then for goodness sakes, that's what you should do. And seek an area that's going to allow you to do that. And that's usually going to be in a private practice setting. Fine. If, on the other hand, you love thinking about different ways to solve problems, and you really enjoy going to the lab, and you really enjoy writing, well, then you should go academic. So both are of equal value. All good work is of equal value, in my opinion. But you want to do something whereby you go, I love this. Not something whereby you think, I'm doing what I think my parents would want me to do. At the point in time when by the time you finish your residency, there's only one person in the world you need to satisfy, and that's yourself. You are the final arbiter of what you are doing and the final judge of your moral and ethical character.
That's very strong. That's very important advice, I think. So, for Ralph Clayman then, what do you do to relax? What do you like? What are the things that you enjoy, other than operating and writing and doing all those things?
Well, you know, most of all, I enjoy being with my family.
Yes.
Period. I mean, you know, being with Carol is fabulous. Spending time with my children, with Matthew and with our son Bradley, and now with his wife Melanie and a grandson Casey. That's primo. Relaxation. You know, there's a variety of things. Whether it's enjoying wine, thinking about ways to roast coffee, reading books about the Civil War, taking courses in other areas about which I know nothing. I think every year you ought to do something that brings you out of your comfort zone. So right now I'm trying to learn how to code. Taking a course on that. I'm taking the AUA course on the Young Career Awards, the K Awards. I'm never going to get a K Award, but I figure if I take that course, I'll be better able to mentor people who are going to be candidates for that. So I'm taking that course. So those are things. I mean, you know, and then you do things that scare you a bit. So you go skiing here at Jackson Hole, and you go off something where you go, I don't know about this, right? And at the end of it, if you're intact, you go, that was good. You
Parachuting?
know, no. Yeah. The only parachuting I do is when I hit a mogul the wrong way and I'm up in the air short period of time. But you know, it's that Eleanor Roosevelt thing about doing something every day that scares you. But things like that also then enrich you. That kind of stress is a good stress and helps you to grow. And so you should never run out of things like that, because the world is so huge. There's so much in the world. I love going to theater. There's a zillion things in which I'm still very much interested in.
How about the future with the landscape that we have in healthcare? What do you think will be our role in all this? Because majority, more than 70%, they're employed by a health organization.
Yeah. I mean, you know, at a very basic level, a country that cannot take care of all the people that are within its borders is not a first world country. And in my opinion, America is no longer a first world country, period. The inability to provide health care to all of the people that are in your population, regardless of where they come from, but if they're in your borders, you're going to have to take care of them, is essential. How you do that is difficult, and no one nation has, as far as I can tell, the solution. Because if they did, then everybody would follow that. So we're still feeling our way. You know, to my mind, to my simplistic mind, the simplest thing is Medicare for all. Fine. But obviously the logistics to achieve that are extremely, extremely difficult. And because it's been politicized, it becomes even more complex to actually come to a fair and just situation where every person is going to have health care. You've got to be able to do that.
Well, actually, I'm very optimistic with this conversation and what's going to happen to our specialty. So thank you so much.
Thank you
for everything you have done, you still do, and you will be continue doing.
Oh, I appreciate it.
So I think this is very important. Thank you for allowing me to do this and continue with the legacy of Ralph. So
yeah, well, it's a wonderful thing you're doing with the meeting. The meeting is absolutely unique, and you've continued it in the way that Ralph Hopkins created it, which is really impressive. And you know, when I come to this meeting, I learn a tremendous amount. It's like I remarked to Rob Uzo today. I said, I feel like I'm at a boards course, but the good news is I don't have to take the boards.
Yes, that's a good way of defining this meeting. All right, thank you very much,
Thanks, Fernando.
Dr. Clayman.